started. Woo! I started. Kaylin, will you hit the light for me? Thanks. Hey, everyone. Welcome, welcome. And hello. Oh, there we go. Okay, y'all can still see me well online? It looks like you can, so I'm gonna go with it. Hello, everyone. Welcome. Happy Wednesday. For those of you that haven't worked with, which is just a couple, I'm Dr. Gibson. I'm the newborn hospitalist here at Richland. So you'll see me when you do your newborn rotation. And today we're going to talk about neonatal abstinence syndrome, or NAS. So let's get going. Oh, and I have the chat pulled up. I'm going to try to periodically kind of look in there for things. So I will answer your questions, and y'all just raise your hand and we can, super informal. All right. Maybe. Okay, what we're going to do today, these make very clear sense. So we're going to understand what is NAS and identify those patients who are at risk for it. You're going to be able to determine what symptoms constitute NAS, and then what do you need to do to manage these babies. I will start by saying I'm not a pharmacologist, so there's a lot of pharm in here, and I apologize if I can't answer questions that you have specific to pharm. But if you have questions that come up, we can look into it and I will get you an answer. So again, I apologize. So what is NAS? And this is actually an interesting question because, and I feel like sometimes we talk about this in the nursery, NAS really is a broad term. Okay, a lot of times we use it synonymous with opioid withdrawal, but NAS really means any kind of substance that the baby is exposed to in utero that could affect them after delivery, whether it's true withdrawal or just a toxicity that kind of is self-limiting, or even long-term lasting effects. So NAS is kind of that general term that we use. This past year, they've started to publish a new term called NOWS, or neonatal opioid withdrawal syndrome, that's specific to opioid use in pregnancy. So you will start seeing that a little more, just to give it a little more of a specification than NAS, which is, again, more of a broad topic. This is a history of opioid use, which I think is kind of interesting. So morphine was first isolated in the early 1800s. The first documented case of neonatal abstinence or neonatal withdrawal wasn't until 1875, and they were actually the reason that wasn't picked up is there was some concern that opioid use in women caused infertility or decreased sexual drive, which is so true. But so that's why the first case really was documented at 1875, but probably happened a lot earlier than that. They started treating neonates with withdrawal in 1903. So there was a little gap there. You can see where Subutex was developed and methadone showed up, but honestly and truly, the epidemic of NAS wasn't really identified until 2012. So that's a long time of babies possibly suffering with symptoms of withdrawal that we didn't really have a good plan to address these on a national scale, which is kind of sad. So the problem today, or more recently, is more of the population, specifically our pregnant mamas, are using illicit substances. And y'all have seen this in clinic and when you're in the nursery and the wards with babies who had the effects of that. So a 2009 national survey showed that the use of illicit drugs had increased that year by 8.7%, binge drinking and heavy alcohol use by almost 24%, and the use of tobacco products by almost 28%. And y'all, that was in 12 years of age and older. So these are your adolescent patients too. Okay, so keep that in mind when you're seeing your teenage well visits. Specifically in pregnant women, so 15, which is crazy, to 44 years of age, 4.5% of those surveyed reported use of other illicit substances that you see there. About 12% reported to heavy or binge drinking during the first trimester, and then about 15% reported tobacco use. The CDC has a fantastic website, and this is one of the images from that website. And I'll mention this a couple more times, but this is so great to direct parents to, especially if you have, if they have questions about, the effects on their baby, or issues about NAS or tobacco use or anything during pregnancy. This is a great resource for them. So this was showing data from 2016. The rate of overdose deaths in women went up by about 20% in 1 year, y'all. 1 year. The opioid use disorder in pregnant women had increased by 4 times, which it comes as no surprise, 4 times as many infants were born with NAS from 1999 to 2014. And to make that a little more concrete for you, in 2014, 32,000 infants in the US were born with NAS. That's roughly a baby every 15 minutes with clinical signs of withdrawal. They did find that in 2014 as well, maternal opioid use disorder was roughly 6.5 out of 1,000 live births, where it was a documented problem during pregnancy. So clearly it's an issue. So I mentioned NAS isn't just withdrawal, and so you have a variety of effects that you might see in the newborn. You can see true withdrawal, which we'll talk about in a little bit, but you can also see acute toxicity. And then in addition to that, long-term behavior or other issues can result. This is a nice summary table. We are not going to go through every single one of these substances, but I thought it'd be nice for y'all to have possible symptoms associated with maternal exposure during pregnancy. You will notice a lot of things are repetitive. So you see a lot of the same symptoms with different substances. So you want to make sure that you have a good drug history on that. So we'll start with cocaine and stimulants. And so this is going to include things like methamphetamine, but also maybe stimulant medication for ADHD. So think about that as well. If you're going to have symptom onset, it's usually that first 24 hours up to day 3. So you can have a baby that comes out with some of these symptoms. Now it also can affect during pregnancy as well, right? So keep that in mind. And most of these effects have to do with a compromised placenta, okay? So you can have premature delivery, you can have an abruption during pregnancy, fetal distress in utero, and a lot of times IUGR babies as a result of that compromised placenta. Effects on the neonate, irritability, fussy baby, tremors, they can get a fever, which is actually, again, very common in a lot of these substances. So it's good to get that history. GI distress, like loose stools, respiratory issues. The big one is apnea. A lot of these babies after moms use stimulants do have periods of apnea that you need to watch for. Poor feeding. They have had documented EEG abnormalities on these kiddos. When you have concerns for seizure activity, they can still have abnormalities on those. And in that same vein, their hearing strain or their ABRs can be abnormal because you know that works in a similar fashion. So is this true withdrawal? Not really. They've done studies where you can get a drug screen on a baby during that first week of life and they pop positive for stimulants or cocaine. So you remember when you're a newborn, we usually get that first void because after that it kind of gets diluted out, and so you really aren't getting a reliable result as to what the baby was exposed to. Not so much here. So these babies, the idea is that stimulant is still in their system for up to a week. So with that, the current consensus is this really is more an effect of the drug rather than withdrawal from the drug, okay? It is self-limiting, but it is definitely distressing to the baby and to families while it's going on. So you definitely want to talk about soothing environments, comforting, lots of skin to skin, all that. You can have some long-term consequences because of this. And so especially if you have a baby with these symptoms after birth, you want to follow them and do their developmental milestones appropriately. Think about possible behavioral issues in school if those come up. Do they need extra resources at school? Maybe, you know, PTOT with some physical dexterity issues. That might be something these kids need help with later on. SSRIs, and before we go into the effects during pregnancy, I do want to do a quick sidebar, and y'all hopefully pick this up from newborn. This is the best antidepressant class for our moms who are breastfeeding, okay? So if mom has a history of postpartum or she has a diagnosis of depression prior to getting pregnant, we want those symptoms well controlled, right? We want a happy, healthy environment for mom and baby to bond, and this might make that happen. So we will allow moms to breastfeed when they're on SSRIs. The one we most commonly use is sertraline. It can cross the breast milk in small amounts, but it is kosher to do, and we encourage moms to breastfeed as long as there's nothing else in their history medication-wise that would be a contraindication. So there's that. During pregnancy, though, you can see effects on the newborn. Usually the onset's within that first week of life as well. And you can see some of these symptoms are very similar, right, as what we saw in the last slide. So is this true withdrawal that we're seeing? The current thought is not really. Now, if you have this in conjunction with opioid use, it can worsen neonatal withdrawal and make it harder to manage that baby and their symptoms more distressing. but an isolated SSRI use in pregnancy is really more thought to be a resolution of a hyperserotonergic state that the baby is in prior to delivery. So it's kind of a coming down process, if that makes sense. Not true withdrawal by itself, but it can make overall withdrawal worse in conjunction with other substances. Marijuana, this is the most widely used illicit drug among women who could have babies in the United States, which I know y'all are probably not surprised about. It's very common. The problem we see is THC is highly lipophilic, so it does cross the placenta, it does cross into breast milk, and it deposits in areas of high fat. Babies are mostly fat, especially their brains, and so that's why it's such an issue for these kiddos. We can see symptoms after birth. I really haven't seen many examples of post-delivery symptoms related to marijuana use. There have been documented tremors and kind of an exaggerated startle and just an alert baby who won't sleep, but there's really nothing much more serious than that I found in the literature. Now, the issue is we don't have a ton of long-term data on the effects of THC, especially during a breastfeeding kind of environment. But the thought is because that THC does deposit in the brain, we may have long-term neurobehavioral issues down the road. So keep that in mind with these families. Also, just in case anyone is moving out of state, even states that have legalized marijuana use for medicinal purposes or otherwise, if you have a mom who is pregnant who comes positive on a drug screen, it is still reportable, even if she got it legally. So make sure that you keep that in mind. Yes.
Can these mamas still breastfeed?
We encourage moms to not use marijuana and breastfeed. So when they deliver here, we actually have a packet we give them, and we ask them to not breastfeed. If we have, you know, honestly and truly, they're going to go home and do what they want to do, but we don't want them to breastfeed. If we have a baby, say in the NICU, that we think would really benefit from breast milk, we have had moms provide milk that we can test just like urine or meconium. And once it comes up clean, we can give moms breast milk. So that is an option for us. Good question. So these I kind of grouped together are hypnosedatives. The first one's barbiturates. So this is very easily transmitted in utero. And you can see high concentrations in different areas, including the fetal brain, liver, and adrenal glands. Really depending on the half-life of this medication, that's going to dictate what effects that you see. Just like the other things we talked about, it can be onset as early as that first day all the way up to a week. And usually it's irritability, GI symptoms. That's kind of how they're going to present. Your benzos generally are low toxicity and can be safe during the labor process. So if you give it while mom is there, if she gets an Ativan because she's just like so freaking out about her pregnancy and about to deliver, that itself probably isn't going to be a problem for the baby. It's more of a chronic in utero exposure that's going to be a problem. It also varies on how mom gets it. If it's an IV formulation, they've actually found more symptoms in the baby after delivery than the PO. And I couldn't tell you why. Symptoms, you see a lot of tone issues and feeding here. You can also see apnea as well with these babies. And alcohol, I hope you like my little commercial ad here. I don't know if y'all can read it, but it says, a case of Blatz beer in your home means much to the young mother, and obviously baby participates in its benefits. The malt in the beer supplies nourishing qualities that are essential at this time, and the hops act as an appetizing, stimulating tonic. Just so you know, I didn't know that. So alcohol use during pregnancy, y'all know that can affect the baby in many ways. You can have symptoms as a result, and it is maybe more of a withdrawal kind of picture, and it can happen quickly, especially if this mom has been binge drinking. And I do want to say that's more so when you're going to see this. It's not going to be, you know, mom had a glass of wine 2 weeks ago. Although we don't like any wine during pregnancy, it's going to be she binge drinks like, you know, a liter of tequila a day or something crazy like that. Lots of GI symptoms, neurologic symptoms. There's your apnea too. Y'all know about fetal alcohol syndrome. I'm not going to go into that, and long-term behavior issues. I will say though that this next one is my, oh, do you have a question?
Yeah, so like if for all of these, like the barbiturates, is it going to be long-term over the pregnancy? Like mom has to have a surgical procedure or something. Like will that impact, or like should she schedule it for a certain time?
So that's a good question. So from the research I found, it's usually chronic use with all of these, right? So if she had a surgery and she got it, you know, 20 week of pregnancy, it's probably not going to affect baby. But if something she's abusing, especially if it's in that last month of pregnancy, right before delivery, that's more so when you're going to see these. Good question. Anything else? All right, so y'all, this ad is my favorite. Taste isn't the only reason I smoke. People are always telling me that smoking causes low birth weight. Talk about a win-win-win, an easy labor, a slim baby, and the full flavor of Winston's. Winston, when you're smoking for two. How fun is it? And then look, there's a Surgeon General's warning. Smoking by pregnant women may result in fetal injury, premature birth, and low birth weight. It's a skinny baby. Who wouldn't want that, right? She also has a martini glass. You see that? Y'all, she's so happy. This is the best. So we'll talk about nicotine. Nicotine exposure prior to delivery can present with withdrawal in the newborn period. You see a lot of tone issues, poor sleep, and GI symptoms. Again, we're kind of doing the same things with different substances. Inhalants, so they're, huffing aerosol cans. What's interesting about this one is these babies can have this weird chemical smell. As they're exhaling, they're releasing those contents that mom inhaled, and so they get this weird odor to them, which is kind of crazy. They can also have metabolic acidosis, which we think might be related to renal tubular acidosis as well. You can see transient issues or persistent ones that can last up to 2 weeks. And, obviously, if you have acidosis, you want to manage that. And you might use some sodium bicarb for that. And then if they use PCPs, irritability, tone issues, eye movements, sudden rapid change in consciousness. And this is weird, y'all. It's like the baby is lethargic and then the baby is, I'm awake, let's go. And then it's like a light switch on and off, crazy. So that's kind of how they tend to present. Question about any of those till we go forward, because the meat of this is opioids. So I want to make sure we've addressed, and I don't see anything in the chat. Anyone remotely have any questions before I move on? Okay, I'm going to keep going. So in utero exposure to opioids is the most common cause of neonatal withdrawal. That's the big one, okay? And we do see NOWs both with prescription and illicit substance use. So if mom is in a methadone clinic, which is great for her and healthy for her, we don't want moms withdrawing during pregnancy, it still can affect the baby. When we have moms in clinic, usually it's a methadone or a buprenorphine or a Subutex treatment program that they're in, and you can see their mechanism of action there. Moms who do use opioids, even if it's, through a treatment plan, can have concurrent polysubstance use, okay? So do get a good history with that. One article said that pregnant women using opioids for whatever reason had an increased use of alcohol by almost 50%, tobacco use by 60%, and marijuana by about 42%. So as we've reviewed, those can cause problems too, right? And I've talked about this a little bit already, but opioid use plus additional substances like these can increase the baby's risk of withdrawal. And I did mention this already, but remember, it's a chronic exposure. It's not just a one-time before delivery. This table summarizes some different types of opioids that you might encounter in this mom's history, and it shows how they're available and how moms might be illegally using them. The NOWs itself, though, in a newborn can have a variable presentation, and it really depends on a lot of different factors. So the type of medication mom was on and its half-life, right? Is it a sustained release or an immediate release medication? That makes a big difference, especially in time of onset to symptoms in these babies. So what was the drug history? Was it, she was in a car wreck, at the beginning of pregnancy and used it for a couple of days and then nothing, and now she delivered? Or has she been in a methadone rehab plan her whole entire pregnancy? It's very different. Moms and babies, they have different metabolisms and excretion rate of these drugs. So every baby's a little different with that. Substances have variabilities in placental transfer. So that can affect things too. And then again, the concurrent substance use. This is another helpful image from that CEC website, kind of summarizing effects we can see during pregnancy and in the baby. In terms of some symptom onset, it's usually that first week. Heroin, and these are all on average, everybody's a little different, but heroin, usually it's within that first 24 hours that you might see symptoms. Methadone, it's usually 1 to 3 days. And then Subutex can be as early as 12 hours, but up to 2 days as well. The ones I see tend to peak around day 3 or so, but we have seen them pretty early. And the hard thing is when you have concurrent substance use, so mom's on methadone, but also uses, you know, cocaine or whatever, that stimulant, it kind of clouds the picture a bit. So you have to kind of take that into account as well. There have been subacute symptoms documented as old as 6 months of age. That's why good follow-up with these kiddos is so important. Did I skip one? No. Okay. So why does this happen? What goes on? There are 2 main hypotheses at present. One is called the disuse hypersensitivity hypothesis. The other one is the alternative pathways hypothesis. So the disuse one, the idea is during pregnancy, mom uses opioids. Those block glutamate and inhibit that neurotransmitter release. With chronic use over time, mom develops a tolerance. So she needs more dosing or higher dosing. And so during that tolerance period, mom's neurotransmitter release kind of approaches more of a normal level as it would be in the general population. But then at delivery in the baby, you cut the cord, those opioids are gone, right? Cold turkey. And so those babies have super normal neurotransmitter release in response, kind of overcompensating. The alternative pathways idea is that during pregnancy, opioids depress the primary pathway of signaling at the neurotransmitter area. And so the body makes alternative pathways to compensate. Well, delivery happens, those opioids are gone, and now you've got an additive effect. You've got primary and secondary pathways that this baby is using. And so that's why the response is so significant. Keep in mind, opioid receptors, you see them in the CNS and the GI tract. And so that's why most of the symptoms are involving the CNS and GI tract. So here are some symptoms listed here. This graph is also helpful. There are some other thoughts of opioid withdrawal, possible other neurotransmitters that are involved, and this kind of summarizes that. I'm not going to go through it because y'all can read, but there are other arguments as well as to what's going on with these babies. So how do we manage? We start by following these babies or following moms during pregnancy and identifying babies who are at risk of possible withdrawal. And so you want to do the maternal history, right? We talk about any illicit substance, but also prescribed ones. Also, remember your homeopathic ones, right? So I don't know if anyone was here for this. We had a huge surge in kratom use during pregnancy, and y'all, there are billboards all over town for this thing. It is it's a leaf, it's a plant that moms can ingest that can have opioid-like effects, and you can have withdrawal from it in the newborn. So think of your herbal supplements as well. And then drug screens, right? So especially if mom is a high risk based on her history, or if you know she has a history of drug use, you want to get a urine drug screen on mom. When babies come out, we also like to get drug screens on them too. So we'll do the urine, and that's helpful because it returns very quickly, but we also like to do a meconium or a core drug screen. And the core drug screen is kind of new in the last year or so. It gives us very similar results to the meconium, and both of them are able to give us exactly what substance and to quantify how much, which the urine really doesn't give us. So that's the benefit of doing both. It also kind of gives you a timeline of exposure too, which can help you manage the baby. So for instance, if the cord is positive, but the urine is negative, it was likely more of a remote exposure. The meconium gets formed at 12 to 16 weeks gestation. The cord is there for pretty much all pregnancy. So it's more like hair testing, where it gives you a long-term exposure set of data. The urine's going to be those last couple weeks or days before delivery. Okay. The next thing in management is you keep mom and baby together as much as possible, right? So no matter what substance it is, you saw a lot of it. You've got irritable babies, fussy babies, soothing skin to skin. Those are wonderful things that moms can do that can help. And we'll talk about when we get into treatment that's the #1 treatment we like in these babies. We also want a good environment. You know, imagine you've had the worst migraine ever. That environment you want to be in is what these babies want to be in. So turn off the lights, turn off the TV or mute it, cuddle under a blanket, nice soft snuggling with mom, get something good to eat. Like that's kind of where you want to be. We do want to use an established assessment or scoring tool, and that takes a little bit of the subjectivity out of it, but I will talk about how that can you can get a little subjective there too. But that'll help you follow these babies over time, and just by shift changes or anything, you can kind of get a consistent evaluation of how these kids are doing. And then obviously, what sort of treatment do you want to do? And we'll talk about both non-pharmacologic and pharmacologic. So let's talk about keeping mom and baby together. Previously, when babies are at risk for NOWS, they actually separated them and took them straight to the NICU, okay? And that's where these babies were kept. And so mom and baby were separated. Breastfeeding, we can breastfeed in the NICU, but it's not as nice as in your own private room. And y'all been to the NICU, that place is super overstimulating, right? So it's not really a good conducive healing environment. Like if I had a migraine, I don't want to go to NICU because it just can't. So it was hard. These babies who went to NICU, they were in the hospital a lot longer. A lot more of them ended up on medications to treat their withdrawal. And then a lot of them were separated from mom for prolonged periods of time, which is never good. So we have more recently switched to keeping these babies in with mom, which I think has made a big difference. So when you room in, and y'all know this, bonding with mom and baby, we can breastfeed, which we encourage in most situations. In general, moms having the babies in the room, their comfort level is going to be boosted, right? They're going to learn how to change diapers. They're going to learn how to soothe and how to feed the baby. They're going to pick up on baby's feeding cues. The big thing I love, especially in this population, is you're going to get parents engaged in their baby's care. And that's the big thing, right? So a lot of these moms, especially those in treatment programs, they know what withdrawal feels like. And the last thing they want is they don't want the baby to experience what they experienced. So they are actively engaged. They want to be their treatment for the baby. And that works so well. And so many of them are really good sports about, you know, putting up with all the assessments and everything, but they obviously want what's best for the baby. And so engaging them in treatment for withdrawal helps a great deal as well. So the first scoring assessment you see here, this is the modified Finnegan assessment. This is kind of the most common one. This is what I had in med school and kind of what we learned about classically. It looks up about 20 different possible symptoms of withdrawal that a baby may have. And this assessment is every 3 hours. The nurse, whoever does it, kind of goes through, examines the baby, scores them, and then adds it up. So it tries to add some objectivity to it. The issue is it is a little bit of subjective as well. So you know what's sneezing because of withdrawal versus sneezing to get amniotic fluid out. You know, it's kind of So I've seen many people score these babies differently. We had a baby when we were doing this, a baby on the floor that got a 12, which is a high score, and got transferred for morphine. And then we get the baby and we feed it and he's perfectly fine. So it's helpful. And if you have nothing else, this is a good thing to use. Keep in mind, you know, always look at the baby and kind of use your brain to think through things if something doesn't make sense. You could do a score with the Finnegan on a newborn who is not at risk for withdrawal and just doesn't like being messed with and get a high score too. So keep that in mind. That's the Finnegan. This is a flow with how the Finnegan works. I will tell you this is from an older article. I liked it because most of the stuff is good, but I'm going to edit it just a little bit to say what's more appropriate nowadays. So basically, if you have a mom on opioids prior to delivery, then you would begin the Finnegan scoring at birth, okay, or soon after birth as possible. And you do it every 3 to 4 hours until they're ready for discharge. If at any point they got 2 consecutive scores of 12 or more, or 3 of 8 or more, so you're adding up to 24, right? Then you would meet criteria for treatment, okay? So at that point you would go, and I guess I did these fancy arrows and then, anyway, so then you would go from there to starting morphine as needed, okay? And so this is an example of a morphine treatment plan with a taper. Now you'll notice you're not starting this wean until 24 to 48 hours. This baby is going to have a much longer stay. When we were using the Finnegan regularly, these kiddos would get a huge medication taper from pharmacy and it'd be 2 to 3 weeks long. So once you did this, you're kind of committed. If the scores were great, if you weren't having high scores, you would just reassess every 3 hours with the idea being that they would follow up and usually they go home in about 5 days and follow up a day or 2 with the pediatrician. So that's kind of how the Finnegan works, which depending on where y'all go, you may still use. And sometimes I think they still use it here in the NICU too. So just so y'all familiar with that. So this is my favorite. So this is Eat, Sleep, Console. And this is actually front page. I brought it here of Pediatric News. Do y'all get this? You see this? Okay, so it's front page, which is awesome. And it's a very bold statement. It says Eat, Sleep, Console approach. It almost eliminates morphine for NAS. How cool is that, y'all? So this is a completely different approach. And the idea is that you are maximizing non-pharmacologic interventions and using moms and dads as treatment. prior to doing morphine or methadone. The first big study, which I'll talk to you a little bit about, was at Yale, but you've seen documented success at lots of other people who published at Boston Medical, Dartmouth, UNC, out in Arizona, and here at Richland. So we're seeing some good results. We've been doing it here since 2018, which is kind of great. So what the Eat, Sleep, Console assessment is it's basically, they took all those 20 questions away, and can the baby do what a baby is supposed to do, is the gist of it. So can they eat at least an ounce or breastfeed well? And I will give them a little bit of wiggle room that first day, because babies' tummies that first day shouldn't be a full ounce. But if they're taking appropriate volumes for their age or breastfeed well, can the baby sleep undisturbed at least an hour? And then when they get upset, can you console them in 10 minutes? So if you notice, all three of those questions, you don't have to touch the baby. You don't have to enter the bed space. You can just ask mom, which is kind of nice. So this is how it works. Here are your three questions. If the answer to any question is no, right? So you could get 2 right and 1 was a no, you bump over here to treatment. If all 3 are yes, you just reassess every 3 hours, okay? And you do that for the duration of the stay. If you bump over here, you'll notice the first treatment is kind of what I've been talking about, non-pharmacologic, right? Using parents as treatment, turning off the lights. The great thing about COVID is that we don't have lots of visitors in the room. We used to have like a million kids running around and like grandma's there and all the friends are showing up to see the baby and they're just passing the baby around. So we used to have to kick a lot of people out. But now it's usually just mom, dad, and baby, which is great for Eat, Sleep, Console. So you would do that, reassess in 3 hours. If we are still failing the Eat, Sleep, Console assessment, that's when you start treatment, okay? And this table actually was from the initial Yale study where they did kind of a scheduled morphine to start. On subsequent ones, they went to PRN morphine. So you get even just maybe a one-time dose of morphine, reassess, and that might be all the baby gets, and then back out to mom. It's kind of great. Questions so far about that? Right, so the trick becomes, because you're looking for withdrawal, right? So newborn periods where it's mostly used, but let's say you have a mom who's on methadone, she goes home breastfeeding, and then you see the baby at, the 2-week well visit, mom's like, I'm gonna stop breastfeeding. I don't like it, I'm just gonna cut her off cold turkey. You might worry about withdrawal, right? Because you don't know what the baby's getting. So I would say, if you have that situation where you have a drug and mom's wanting to stop the breastfeeding, you could use it at least to start. I don't know if it's been documented at higher ages, but if you think the baby's at risk for withdrawal for something that mom has in the breast milk that's going to be taken away, I would probably use it, or at least know the symptoms on it and kind of be looking for those in your clinic. Good question. All right, so we will go into treatment. So, and this is for Rachel, by the way, this picture, because she loves the rock. I just had to sneak this in here. So Rachel, if you're here, you're welcome. So we start non-pharmacologic therapy at birth. You see what I did there? See? Okay. We begin this at birth, right? So if nothing else, hopefully y'all have realized this, it is first-line therapy, decreased stimulation, minimize auto-stimulation, that's skin to skin, that's swaddling, right? And then we do use a modified feeding regimen. So these babies may be breastfeeding, that's perfectly fine. If mom can't breastfeed, maybe she has HIV, maybe she has concurrent substance use and has amphetamines in her UDS, then we're not gonna let her breastfeed. Or if she just chooses not to breastfeed, we will start her baby on a formula, and it's usually one of those kind of gentle tummy formulas, like Similac Total Comfort or Good Start Gentle Ease, or something that's a little bit easier on the baby's belly. We also usually start at a higher calorie formula. There's a lot of data out there because y'all know breast milk is 20 calories. So you may go places where they started at 22 or 24. We usually started at 24 here, but you would not be wrong to start at 22 and concentrate if you had weight issues. But the idea is when you're in withdrawal, you have a higher metabolic rate, and so babies are burning through those calories way quicker than they normally would be. As I've said, we want to encourage breastfeeding. It has been documented to reduce the use of pharmacotherapy in these kiddos because they're getting a little bit of methadone through the breast milk, right? And shown to decrease length of stay. And then obviously you get the bonding there too. There is a lot of data about how long to watch these kids. Here at Richland, we watch 5 days, and that is 5 days provided you don't have symptoms of withdrawal. Because if you're day 5 and you're looking kind of weird, we're going to keep you longer days, more days, right? But at minimum, AEP says at least 72 hours, and most places it's 5 to 7 days. It's kind of the average. Methadone, usually you're going to see symptoms by day 5, sometimes to day 7, and then Subutex or more of a sustained release one, it might be day 4 to 7. So that's one of the reasons why we like these kiddos to fall up so quickly after they go home. So here's the pharmacotherapy, more of it. Now, we talked about, especially if you're looking at Eat, Sleep, Console, you have just those 3 things to go off of. And I don't want us to ignore other possible symptoms of withdrawal because you're like, but they passed the 3 things. Does that make sense? So even if with Eat, Sleep, Console, that is looking good, but you have signs of dehydration. Baby has a lot of loose stools and has lost a lot of weight. Baby has a fever. Obviously, baby has seizures. So regardless of whether you are failing or passing your assessment, you need to look at other things too. And just don't turn a blind eye to the fact that, he's having really loose stools and his bottom is tore up because of it, but he's passing his Eat, Sleep, Console, right? And again, you use this in conjunction with non-pharmacologic therapy. So even starting methadone, for instance, you still, as much as you can, try to get that nice, soothing environment for baby. First line management, depending on where you go, morphine, methadone, one of those is probably your go-to. Between here and Greenville, it usually has to do with what's available at our pharmacy. So here we use morphine, Greenville, I think they use methadone. There's some data with Subutex, and the next slide I'll go into these a little bit more. And then you could use a secondary medication, especially if you're not getting symptom management on one substance alone. And for that, you would use clonidine or phenobarb, which me personally, I'm not a fan of, but we'll go through that. So again, morphine and methadone, these are your 2 primary ones. The big thing with morphine is a short half-life, so you have frequent dosing, okay? So you start dosing Q3 hours with these kiddos. They're getting it a lot. It is an oral medication, so you don't need an IV, and babies actually really like eating it. So what I've seen is they don't have a hard time with it. There's no alcohol content, which some of these do have a higher alcohol content. Morphine has a lot of sedation issues, especially if the dose is too high. So apnea is a real problem. So when we get these kiddos on morphine, even if it's a PRN dose, we watch them on monitors for at least that first 3 hours to make sure we're not going to have apnea or any other spells. And then you can also see constipation too. Methadone has a little longer of a half-life, so it's initially dosed BID, which is nice. It does have a little bit of a higher alcohol content, but they have found that babies on methadone need treatment longer. And I think that has to do with that longer half-life. So they get started on it and they might have symptom resolution because it might take you longer to get them off. So keep that in mind too. So below the line I put there, we've got phenobarb. This has a very long half-life. It has a very high alcohol content. There's a lot of sedation here. So I'm personally not the biggest fan of it. If I use a secondary agent, I usually add clonidine. They don't have alcohol in it. You don't run the risk of sedation, but you got to watch their vital signs, right? This is a blood pressure agent. So you want to make sure that you're monitoring the baby's pressures and you don't just stop it, right? Because you can get rebound blood pressure issues. So keep that in the back of your mind. Subutex, some people use it. It has a 30% alcohol content, so I'm really not encouraging it. It also does not work by itself. You have to use that in conjunction with something else. So keep that in mind too. Questions about these? Okay. All right, so the Yale study. This is the big study that started with Eat, Sleep, Console. So I wanted to go over it just because it's something you'll probably encounter. It actually started as a QI project. How cool is that? So their AIMS statement was to reduce the average length of stay for infants by 50%. That was their goal. They took baseline data from 2008 to 2010, and their QI project lasted from 2010 to 2016. They had about 287 infants involved, and the inclusion criteria were babies with documented symptoms of NAS, at least 35 weeks gestation. And then for this initial study, they did subsequent ones, but the mom had to be on a methadone plan, at least for 1 month prior to delivery. So these were the 4 non-pharmacologic interventions that they used. So we talked about the low stim environment. They engaged the staff, which I think is so important. So the staff were encouraging parents to participate in their baby's care. They also trained the staff and the families that non-pharmacologic equaled treatment, right? It wasn't just like, oh, this is just something we're doing. It equals treatment, just like if you're trying to, talk up a placebo, right? It's the same kind of thing. And then they encourage breastfeeding. This is, I mentioned here the PRN morphine, that's the dose they got. And then they actually did a more rapid morphine taper. So if the kid was good, every 8 hours they would start the wean. So they get them off these medications a lot quicker. So these next few slides are just their results, which I think are fantastic. Remember, their aims was to decrease length of stay by 50%, right? So back here, this is their pre-data. Their average length of stay is 22.5 days. They ended at 5.9. That's an awesome QI project, y'all. That's fantastic. So there's that. You can see all the interventions that they did. Percent treated with morphine, 96% to 28%. Interestingly enough, percent with at least 50% of their feeds breast milk went up from 20% to 42%. So that was a happy result. And then remember I said most babies start at the NICU. So here 100% of these babies will go to NICU. They ended without 27 needing to transfer for medications. That's fantastic. And then because we care about cost and, the average length of stay for these kiddos was just under $45,000, ended up about $9,500. So lots of good data here. UNC, which has, I think, some amazing tables. Look at that. Oh, and that's a cute baby, right? So cute. So here's their data too, their baseline data. So this was for the number of doses of morphine. So you see how drastically that changed. And here's their length of stay as well. So they're seeing lots of benefits here. And just because, I'm so proud of us. And thanks to Josh and Megan for helping us compile this. So average length of stay went from 10.5 to 7.2, or if you're correcting for some babies with other medical issues, 9.7 to 5.9 over the course of their QI project. Total number of morphine doses went from 629 during our pre-data period to 118 since 2018, which is way improved. And this is as of today. This is our updated data. So we've had 46 babies do eat, sleep, console. The average length of stay is 6.8 or 5.3 days. So we're even continuing to improve. And do y'all know who this is? This is Dr. Holloway's kid, Jackson. Yeah, I cute. All right. So, and we are heading up the end, so this is great. So let's talk about discharge. Every time you deal with a pediatric patient, whether it's in wards or clinic, your big thing is setting that family up for success, right? You want to give them the tools that they need. These babies are no exception. They definitely have a high risk for readmission, whether it's for withdrawal, non-accidental trauma, poor weight gain, any number of things. So you want to make sure that these moms have all the resources they need. But when can you discharge these babies? You want to monitor them 3 to 7 days, here 5 days, without any signs of NAS. If you start morphine, they need to be monitored a day or two post the last morphine dose, okay? So you want to make sure that you were able to wean off safely and the baby didn't have any rebound symptoms, okay? So don't just take them off and then go. I put this in parentheses. There is some information out there about outpatient pharmacotherapy. Some institutions do it, and there are some papers out there. The AAP really doesn't endorse it. There's a lot of user error with that. The risk of overdosing or underdosing, the safety of it, that sort of thing. So depending on where you go, you might see some outpatient pharmacotherapy, but at this time, it's really not encouraged by the AAP just because of all the variables that come into play. As with all of our babies, you want to talk about your social system. Does mom have good support? Is there someone there who can help make sure this kid gets to the appointment in a day or two to be watched? Does mom know if we're doing this, the specialty formula, does she know how to mix it? Is she good and set and comfortable? Do we have a good medical home? Do we have a pediatrician and they're going to follow up within a day or two? Does mom need outpatient lactation support, or is she, good? A lot of these babies do have long-term developmental issues when they are diagnosed with NAS. And so as a pediatrician, follow those developmental milestones, refer to development clinic or other interventions if you feel like they're not meeting them. Some of these babies are also have been found to develop ADHD or other attention issues later on in life. So keep that in mind as you're following these kids when they get older. And then overall caregiver comfort. There is a huge risk of co-sleeping in this population and a huge risk of shaken baby in this population, right? And it kind of comes with the territory, right? If you have a baby who won't sleep, you're just going to tuck them in with you and just take a nap, right? Or that baby won't stop crying. So these are things that you definitely need to make sure we educate parents on. We have a safe sleep space. Mom knows, it is fine to put the baby in crib and just walk away for a few minutes and take a breath, right? So safe sleep, shaken baby. Online resources like the CDC, lots of parental stuff there. So I direct them to that because we want nice, healthy babies. So speaking of resources, here are mine. I highlighted this one right here. That is this book. And if any of you in general, but also third years are looking to use your CME money, this is so fantastic. It's called Neonatology for Primary Care. And it goes through neonatal issues and how you as a general pediatrician can interpret them and deal with them. So I love it. It's by the AAP. It's fantastic. So I don't know if y'all can see. There we go. And y'all are welcome to look through this if you want. I have it here for you. And that's all I got. Does anyone have any questions? Yes. Okay. Yeah. So the question was, make sure I get this right. So besides the timeline of exposure, is there a more accurate way to get the drugstore in the baby urine versus meconium versus cord? So that's a great question. The issue is, at least here, the meconium and the cords are send out labs. So a lot of times we don't have those before discharge, because if I had my way, I would get meconium or cord. It gives you the exact substance and the amount. And so that I think is way more helpful to me. The urine is something we do here in-house and we have it back in a few hours. So a lot of times that's my preference because I can decide how to treat the baby today rather than, well, we might have had opioid exposure. I don't know. Let's just kind of see if the baby develops symptoms, because that meconium and cord aren't going to come back. So the timeline to results, I think, is a big push to get that urine too. But otherwise, personally, the meconium and the cord give you way more information. Good question. Anything else? I don't see anything online. I don't see anything in the chat. Okay. All right. Y'all have a wonderful day. Good seeing y'all.